All right, well, let's get started and transition into grand rounds. So in just a minute, I'm going to ask Dr. Montero to introduce our grand round speaker. Um, with regard to attendance, we'll be taking attendance looking at the participants list at 8:10. If your name is listed clearly, you'll get full credit for attendance. If anything else is the situation, you can email your attendance to me, to Beth, or Michelle. Dr. Silverberg was supposed to introduce our grand round speaker, but he's been tied up in a gynecological emergency. And so Dr. Montero has graciously offered to fill in. Dr. Montero, can you introduce our speaker?
Thank you, Dr. Ebert. It is my pleasure to welcome Dr. Matthew Drago to Rutgers OBGYN Grand Rounds today. Dr. Drago is currently an assistant professor of pediatrics and the director of neonatal ethics and palliative care at the Icahn School of Medicine and Mount Sinai Kravis Children's Hospital. Dr. Drago earned his medical degree in Masters of Bioethics from the University of Pennsylvania and went on to complete his pediatric residency at Children's Hospital of Philadelphia and did his neonatology fellowship at Columbia University in New York. His research is in bioethics, specifically in studying ethical challenges of caring for infants with life-limiting conditions, infants born at the border of viability, and infants born to incarcerated mothers. His talk today couldn't be more timely. The topic, how to navigate the moral challenges of periviable birth. Please warmly welcome Dr. Drago. It is such a pleasure that you're here today.
Thank you so much. Thank you for having me, and really excited to talk to everyone today. First, can everyone hear me okay?
Yes, loud and clear.
Perfect, and slides are up, so just please feel to let me know if something goes awry. But I have no financial disclosures to discuss today. And our agenda for today, I'm going to talk a little bit about periviability, define periviability, put it in a historical context, and share some of the data and what some of the professional guidelines tell us about periviability. I'm going to talk about perinatal counseling, some of the difficulties that come up with within perinatal counseling for periviability, and some of the ethical perspectives that I think underlie some of those issues, and hopes to present a perspective that might be used in the future and share some future directions that we're researching at Mount Sinai as well. So when I talk about periviability, what I mean is the earliest stage of fetal maturity wherein there's a reasonable chance, though not yet a high likelihood, of extrauterine survival. And when I say that, what we might envision then in our minds is this picture of the neonate on the right, who is connected to multiple devices, who's very small, who's in intensive care. This is from a decision aid that I had helped make with Ursula Guillen and Harish Kripalani when I was at Children's Hospital Philadelphia, which we validated in a Spanish-speaking population, which is why the words are in Spanish. But I think it's interesting as we get started to think about periviability from a historical perspective. And so the picture on the left is actually that of a newborn in one of the first incubators. So Tarnier, who is an obstetrician in France in the late 1800s, was the developer of the incubator. He had gone to a zoo in France at the time when French nationalism was calling for a way to help save more newborn babies. Mortality rates were rising, maternal mortality rates were rising as well. And so there was a call to save the newborn population. And he saw that they were taking care of chickens in incubators at the zoo and incubating them, and they were hatching it and doing well. And he thought, why can't we do this with newborn babies? Because at that time, newborns were born in the home with a midwife, or they would call for a doctor to come into the home to assist. But then the newborn was taken care of in the home. It was the responsibility of the mother and the midwife to provide the baby with heat and nutrition, to get the baby to suckle. And if that didn't happen, then the baby became moribund. And it was only at that point, when the baby was moribund, that the baby would be brought to a hospital essentially to die. So the first babies' hospitals were really palliative in many ways. And these were babies who were a little bit small or had trouble with eating. So your late preterm infants that we think of now, very different from the periviable infants that we're going to be talking about today. And so you might think that by discovering this technique and being able to keep these babies warm, and another nurse at the time was also developing gavage feedings, that this would have been acclaimed and would have received widespread acceptance. However, that was not the case. Tournier received a lot of criticism. To think about taking a baby away from a mother, which was the natural state, from an open bassinet, and place them into this enclosed box seemed completely unnatural. It went against the thinking of the time in which disease was from being kind of enclosed and in tight spaces, and you needed open air to get better. And so this kind of went against that vein. And so he received a lot of criticism for it. And actually a lot of resistance to implementing this into hospitals to help save these quote unquote periviable infants. So enter in Martin Cooney, who's an American physician, was very interested in this technology, goes to France, learns about the incubator and the development, brings it back to the United States in the early 1900s, around the times of the World's Fair in Chicago. And he goes around to all of these different exhibits, and he essentially establishes a sideshow where you can pay a fee to see a small premature baby. And he hired nurses to take care of them. And he would travel with the different exhibits across the country, and eventually established a permanent exhibit here in New York on Coney Island. And this was really the start of neonatology in America, because hospitals were still resistant to implementing this technology. It took almost half a century for the first NICU to be developed at Yale University in the 1960s. And that, of course, coincided with the birth of a president's son who was premature and died of complications of prematurity. And I would ask the audience if we were in person, if anyone knows who that president was, but I'll tell you it was JFK. He had a baby who was born late preterm, but had severe RDS, and unfortunately died. But if that baby was born today, would have had nearly 100% chance of survival. So it just shows how far we have come, but we're still facing the same question of what to do on the edge of technology and implementing technologies, and what's the right way forward. And so I think that's a really interesting historical perspective to think about as we talk further about periviability in the in the modern era. And in the modern era, when we talk about periviability, we're not talking about late preterms of 34 to 36 weeks gestation. We're talking about a window typically of 22 to 25 weeks gestation. So this was a systematic review published by Ursula Guillen et al. in Journal of Pediatrics in 2015, where they looked at professional guidelines internationally and what the recommendations were for periviability or extremely premature birth. And as you can see here, at that time, most of these guidelines were published in the early 2000s to mid 2000s. At 22 weeks, it was generally, there was consensus that comfort care or palliative care only should be offered to these infants. And if you look at the other end, at 25 weeks, there's general consensus that active care or a trial of resuscitation should be offered to the child. But we see a bit of a gray zone at 23 and 24 weeks of gestation, where some are recommending an individualized approach, some are deferring to quote unquote parental wishes, others are offering comfort care, and we see kind of a more gradual shift at that period of time. So what is really informing these recommendations? What does the data really say in terms of outcome as to why there is these general consensus within periviability, and how has this shifted over time as well? And so I'd just like to start, if you wouldn't mind putting into the chat, I'd be curious to hear, what are you guys doing at your institution right now in terms of what is the lowest gestational age at which resuscitation would be offered? So here I see a response for 22 weeks. Is there general consensus then at 22 weeks? Wonderful. Well, it's good that everyone seems to be on the same page. So some of the data shows how we've gotten to that point. This is from an update chapter I wrote with Mark Procure on periviability, which we exhaustively looked at all the different data that we have on periviable birth that's been done over the years. Excuse me, one second, take a water. We find that Tyson in the late 1990s, early 2000s, did a study on periviability with a cohort for the National Neonatal Research Network here in the United States. And so this is up the bottom row that you see on this table before you. And when they looked at survival for these infants at the various gestational ages, we saw that at that time, in the 1990s, early 2000s, survival for 2-week infants was only 5%. At 23 weeks, it was 26%. 24 weeks, you start to see a significant improvement up to 56%. And then by 25 weeks, you have 75% survival. But at that time, it was generally being followed the guidelines that I was sharing with you before, which really was recommending palliative care only for infants at this gestational age. And so there was a concern that, is this a self-fulfilling prophecy? Are we seeing these poor outcomes because we're not offering resuscitation for these infants? And as time went on and the research study was repeated in 2013, 2018, the Neonatal Research Network saw that there was an improvement in survival. So if you looked at the top row, which was for the entire cohort of patients, survival now is up to 11% for 22-week infants, 49% for 23-week infants, so closer to what it was for 24-week infants in the prior cohort. It was 70% for the 24-weekers now and 75% for the 25-weekers. But what they also were discovering was that they looked at that question of, were infants receiving active treatment or not active treatment, and found that the approach of the institution did impact survival. That for those infants who received active treatment, survival for 22-weekers was as high as 30%. For 23-weekers, it was 56%. And then not much difference between in the 24 and 25 weekers in regards to the entire cohort or active treatment, which may show that there is more consensus in terms of the approach to the 24 and 25-week infants. So you can see that over time, we've gotten better at taking care of infants who are periviable in regards to neonatal and obstetrical care. And we've also shifted our mindset around offering resuscitation for these infants. But survival obviously isn't the only part of the story. What about neurodevelopmental impairment? So fortunately, the data here is a bit conflicting. Some studies have been published, for example, the Epicure study at the UK and studies here in the US have shown that there was increasing survival without improvement in neurodevelopmental outcomes, which was concerning in that we were getting better at keeping these babies alive, but we weren't necessarily getting better at preserving their neurodevelopmental status. Other studies, however, showed that there was increased survival with less neurodevelopmental impairment, that as we were getting better at keeping them alive, we were also getting better at minimizing these morbidities. So, for example, studies out of Australia, the Neonatal Research Network cohort study, the Swiss and the EpiPage study out of France. And then lastly, there are some mixed data. For example, the Neonatal Research Network in Japan showed that there was downward trends in mortality and cerebral palsy, hearing and vision loss, but no change in cognitive outcomes. So I think we see a mixed bag in regards to neurodevelopmental impairment. I think this is partially because it's a lot harder to define neurodevelopmental impairment across research and many more factors that may confound outcomes, but the data points are still out. So one question then is, since we've seen a shift over time in terms of what the edge of periviability is from offering only palliative care to 22-weekers in the early 2000s to now seeing growing survival of 22-weekers by offering them resuscitation, will the lower limit of periviability go even lower? And all of you are very well versed, obviously, in embryology and the fact that with fetal lung development, we do reach a biological implausibility in terms of conventional ventilation in being able to have enough lung tissue and airways to actually oxygenate and relieve carbon dioxide from periviable infants. which has led to some of the more cutting edge research to start to look at alternative modes of taking care of these infants. So there's currently two modalities that are being studied right now. This is the extrauterine environment for neonatal development, or the EXTEND trial, which is out of the University of Pennsylvania under leadership of Alan Flake, who's a surgeon there. And what they have done is they've created this biobag system in which they have been able to maintain fetal lambs that are similar in gestational age to periviable infants, 22 to 24-week infants. And they enclose them in this artificial amniotic fluid that has continuous flow and also antibiotics to decrease risk of infections. They have cannulized the umbilical vessels of the lamb so that the lamb's native heart can pump blood through an oxygenator, the same oxygenator that you would use in an ECMO circuit. And then they're able to give TPN and nutrition via those catheters as the oxygenated blood goes back into the lamb. They have been able to keep lambs alive in this system for up to 4 weeks, with the goal of this to be to bridge periviable infants from that 22 weeks where survival is 10 to 30% to get them to be 23, 24, 25 weeks of gestation, where now survival might be 70%. There is a lot of ongoing conversation and work in this area. Journal Perinatology in December published a number of articles discussing how they might make the leap to human clinical trials in the near future as they continue to compile animal data. But I do think that this is something that will reach human trials at some point in the coming years. The other system that's being studied is referred to as so this is the artificial womb, because the lamb is in a fluid environment like the uterus. But there is a separate system being developed out of the University of Michigan, which is the artificial placenta. And in this system, the infant is delivered and placed onto conventional ventilation. And then if it's determined that the infant does not have enough lung tissue to oxygenate and ventilate the infant, then they are transitioned essentially onto an ECMO circuit and tried to maintain for then transition back to conventional ventilation at a later period of time. So a lot of differences between the two different systems, lots of conversations about how we might select patients, a whole nother topic conversation, but I think important to talk about what might be coming in the future. But we've been talking a lot about gestational age and what the cutoffs are, thresholds are for resuscitation for periviable infants based on gestation. What are other factors that might help us then in making determinations for which infants will benefit from a trial of resuscitation, or which infants do we feel more confident that it would be in their best interest to withhold a trial of resuscitation? And so the National Research Network and the NICHD studies in the United States looked at a number of other factors that we know influence outcome. So we've been talking a lot about gestational age, but for every 100 grams of birth weight, it's similar benefit or detriment to survival as a week of gestational age. Same for being a female versus a male infant, being a singleton versus a multiple, and having antenatal steroids versus not having antenatal steroids. And so they put together this NICHD calculator, which is publicly available online. I use it frequently before going into periviability consults, just to get myself oriented to numbers. And you can see here by plugging in, if you had a 23-week infant at 600 grams, who's a female singleton and had antenatal steroids, looking at what their chances of survival of being of 22%, and looking at also their neuromental outcomes. So this seems like a really great tool that it individualizes some of these prognostic numbers for parents and gives them more of a rich picture based on the individual and factors and some of these other things that we know influence survival for periviable infants. But part of the issue that comes forward then is, how do we draw the lines? If we're not creating these thresholds on when it's impermissible to offer resuscitation because outcomes are so low, when it is permissible to offer resuscitation and let parents be involved in shared decision making to make that decision, or when we reach a threshold in which the outcomes are so good that a trial of resuscitation is obligatory. If we're not doing that based on gestational age, what percentages are we going to use? So the British Association of Perinatal Medicine has published an updated guideline that does use these different factors and uses percentile chances of risk for survival and neurodevelopmental impairment. And what they have said is that if you're at extremely high risk, greater than 90% chance of death or of survival with unacceptably severe impairment despite treatment, that their recommendation is to provide palliative care, and life-sustaining treatment should not be offered for these infants. If you're in the 50 to 90% chance of death or survival with severe impairment, or the high-risk group as they call it, then they say we should defer to parents, that they should be counseled carefully, and parental wishes, again, note that terminology of wishes, should inform a joint decision. And then lastly, in the moderate risk group, there's less than a 50% chance of death or surviving with severe impairment. That is when they make their threshold of that active management would be in the best interest of the baby, and potentially override parental judgments to withhold trial resuscitation at that time. That's very interesting that those are the cutoffs that they used. Again, that 50% threshold for making resuscitation obligatory for periviable infants. When I was at Yale University prior to coming to Mount Sinai, we went through a process in which we had MFM, OBGYN, neonatology, nurses, and family come together to discuss the same issue, to talk about, well, what would be the percentage that we would use in this? And we came up with a threshold of 66%, that if there was greater than 66% chance of survival without neurodevelopmental impairment, then we said that there was an obligated trial of resuscitation. And again, remembering that despite this determination of resuscitation for the periviable infant with a high likelihood of survival without profound disability, the maternal right to autonomy and bodily integrity remains. That is, regardless of the status of the prognosis of the fetus, a woman has the right to refuse any of the interventions on herself, including but not limited to antenatal steroids, fetal monitoring, induction of labor, or cesarean section, or transfer to another facility who might treat it differently. And similar to the lower threshold, for example, if an institution that was only resuscitating as low as 23 weeks, but a sister institution would be willing to resuscitate at 22 weeks. So again, I'll ask the audience here, if we were transitioning to a system based on percentage chance of survival versus gestational age, where might you draw the threshold? Excuse me, let me go back. In which the neonatal resuscitation should be obligatory, above what chance of survival without profound neurologic impairment, above 33%, above 50%, like the British guidelines, 66%, like the Yale algorithm that I mentioned, or should it be even higher? Should we only be making resuscitation obligatory for infants at 75% chance of survival, or should there be no limit? I'd be curious to see what people think. Feel free to put into the chat where you might draw the threshold for having resuscitation be obligatory for periviable infants. Maybe no one's willing to put their money down. I see one vote for 50%. And again, it is very difficult because it does seem arbitrary. So perhaps no limit. Perhaps we need to be more individualized across. So I think that this highlights the point that I think that this transition from gestational age could be very tricky to put out. The other important thing that's recommended in all of this as well is thinking about your local data, or how your institution does comparative to what's published in the NICHD calculator, and nationally, and internationally as well. So here is a chart of our local data at Mount Sinai Hospital, which we track, and important to track to see what your outcomes are. So our outcomes, I think, are similar to that I've been sharing from national data, of around 50% survival for the 22 and 23 week infant. Again, I think depending on year to year, I've seen this number shift up and down, especially when your N is so much smaller for the 22 and 23 weekers. But then by 24, 25 weeks, we start to see that shoulder in terms of our percentage chance of survival. Much harder, though, I think, to get the nuance of detail in terms of weight, sex, whether received steroids or not, multiple or not. Again, when your numbers are so small, which is why I think the calculator is really great just for just general orientation, but very difficult from a local perspective to apply those same rules. What's interesting is when you look at these professional guidelines in the care of extremely premature neonates. I did a study with a medical student when I was at Yale, reading through the guidelines, because someone mentioned in the chat, well, these seems arbitrary. How do you really draw these lines? And we looked through it. What were some of the ethical principles and considerations that the guidelines stated explicitly in drawing these conclusions? And what we found was that the guidelines were very good at listing all of the survival data, the clinical steps, things that we, in doing our qualitative analysis and reading through it and then putting things together under categories and themes, we called clinical reasoning. Basically explaining the steps of how you might approach the clinical problem of paraviability, talking about counseling practices, again, clinical care management, dealing with data and uncertainty. But there was a lot less explicitly stated in the guidelines around the ethics underlying where they drew those thresholds. So some spoke about principlism. So the 4 bioethical principles we're all familiar with: justice, beneficence, autonomy, non-maleficence, and talked about balancing of these principles as part of the reason for drawing their thresholds where they did. Some talked about rights-based approach. So for example, the right to life of an infant, or the right to mercy or dignity if an infant has a poor chance of survival. More tended to fall under the realm of consequentialism, looking at outcomes, balancing outcomes, looking at mortality, prognosis, morbidities, and quality of life. And whereas all of the guidelines listed issues under and considerations under clinical reasoning, just over half listed explicitly an ethical considerations or ethical theme that underlined their professional guideline. And so I think that our recommendation for those that write these recommendations moving forward is that there needs to be more open and explicit discussion for what some of the issues and ethical considerations are in drawing these guidelines, because again, I think that it can seem arbitrary at times as to why we choose a certain cutoff to obligate either withholding or trialing resuscitation. And what about parental preference or parental judgment as well? As I mentioned, a number of the guidelines state that we should prefer to parental wishes, which I think is an interesting term, because when we think about our judgments or institutional philosophies, if you will, around paraviability and what we recommend, we're doing that by looking at the data, looking at our outcomes, but also considering the values of parents. And there have been studies to show that when you interview parents about what's important to them in perinatal paraviability counseling, we find that their values, religion, spirituality, hope matters a lot more to them than the statistics that the physicians are providing them. And some felt the decision was out of their hands, it was in God's hands. And for many, the decision was already made, that it wouldn't matter what percentage chance that you were listing for them, they had made a decision either to go forward or to not go forward. And so I think we have to consider the importance of that and the weight of that, and especially in that zone of parental discretion, in which we're saying that our outcomes are so uncertain that we don't exactly know where to draw the threshold, that we really should be deferring to what I like to say more fittingly, parental judgment. It's not a wish, but more that they have considered what you've counseled them on in terms of outcomes and what risks of morbidities their child may have. They've reflected on their own values and then made a sound judgment in the best that they can, given the circumstances, knowing that there are many barriers to providing that. So in summary, these professional guidelines, they provide an up-to-date, transparent data on survival and morbidities. They acknowledge the importance of parental judgment when there is uncertainty in outcomes. But again, we suggest that they should explicitly discuss the ethical considerations and frameworks used to draw those thresholds, especially moving forward as we might shift more towards looking at percentage chance of survivals. So shifting then, I wanted to talk about perinatal counseling. And as you know, obstetric counseling begins sometimes even before pregnancy. As you're talking today, if you have a patient with a pre-existing condition like lupus, asking them to get their lupus under control, what their management of, excuse me, what their management of their medications may look like, doing your hypertension, diabetes screening, et cetera, throughout. But very early on, even talking about non-invasive prenatal testing now in the first trimester, aneuploidy screening, there may be triggers for involving neonatology or pediatric providers in counseling and starting to counsel not only for the pregnant person's health of the pregnancy, but also thinking about the health of the potential fetus or child. And so typically under that mechanism, periviability counseling is sequential. It really begins with obstetric and MFM providers having conversations if there's risks for periviability or preterm labor, and then bringing in pediatric providers who might then have separate conversations. And some studies that have looked at this have shown that there are differing beliefs on when pediatric providers should be consulted to discuss these issues. There can be redundancies in information that provided, and obviously different focuses of information. Neonatologists tend to provide more information on neonatal complications like resuscitation or what comfort care options there are, and more frequently discuss family values, comfort, suffering, and uncertainty, while obstetricians more likely to discuss antibiotic use in preterm labor, if there's rupture of membranes, maternal risks, and C-section risks as well. There can be inconsistencies in the stated prognosis. So I've reviewed how much the data has shifted over time already and just looking at survival for periviable infants. And so depending on whether you're quoting studies that came out in your training or when you learned to do periviability counseling, and if it's shifted, you might be giving different information. You might be also be giving different information in terms of outcomes for C-sections or risk of steroids, et cetera, if you're a neonatal provider, for example. There's also lack of ownership they found in antenatal steroids. Again, it's an interesting thing because it's a medication given for the benefit of the fetus, but prescribed to the mother with risks to the pregnant person. Deferring parental questions to other providers creates gaps in terms of answering those questions. And then again, differences in provider education on perinatal counseling as well. So we know that there are barriers and pitfalls to sequential counseling. And when we talk about having joint periviability counseling, so getting obstetric or MFM providers and neonatologists in the room at the same time, there's wide support for this. 80% of providers on both sides support it, but it's greatly underutilized. Less than 50% saying that they actually go through with it, and predominantly note systematic barriers, timing, conflicting clinical care responsibilities that really prevent them from doing this together. In my hypothesis is that there's also differing ethical perspectives on decision making during pregnancy that may contribute to the underutilization of joint consultation. So, for example, understanding both perspectives might provide opportunity to strengthen periviability counseling. Because again, there's a liminality of preterm birth. The fetus is transitioning to a newborn, the pregnant person is transitioning into a parent. But at the same time, because there's so much uncertainty, there may be a loss of pregnancy, and the pregnant person may be transitioning then into a non-pregnant person and not transitioning into a parent having to make decisions regarding the health of a newborn baby. So there are differing perspectives and studies that have shown there's differing perspectives on the focus of the fetus as a patient versus mother as a patient. With 37% of both MFM and pediatric providers disagreeing that it was reasonable to consider the fetus and mother as separate patients. MFM providers were more likely to disagree with the statement that their focus is on the well-being of the fetus, and vice versa. The pediatric providers were more likely to disagree with the statement that they're focused on the well-being of the mother, showing these biases in terms of who your patient is that you're counseling in these situations. Similarly, Brown et al. Also did studies looking at perspectives on termination and asking whether or not it was reasonable, or asking the percent of fetal care providers, so pediatric providers, or maternal medicine or obstetricians, if they disagreed with that the following factors were not appropriate reasons for a couple to consider pregnancy termination. in the setting of congenital conditions or fetal abnormalities that were diagnosed in utero. So when asking if the presence of the fetal abnormality was an appropriate reason to consider termination, less of the pediatric providers felt that it was an appropriate reason to consider termination than the obstetricians. In regards to effects of the child with disability on the marital and family relationships, again, fewer pediatricians felt that that was an appropriate reason to terminate. And the cost of healthcare with future child was also considered less of a reason by pediatricians than obstetricians. So they concluded that there was, in summary, our data suggests that among obstetric and pediatric specialists who provide prenatal care, ethical sensitivities was the terminology they used about pregnancy termination differ by specialty group. They found similar outcomes when asking about attitudes in regards to decision-making authority in pregnancy. So surveys that looked at willingness to seek court approval to uphold treatment recommendations during pregnancy for fetal well-being, such as ACT treatment or antiretroviral treatment for HIV, enrollment in substance abuse treatment, and transfusion for fetal anemia due to Rh disease. Again, pediatric providers were more likely in these situations to say that we should seek court approval comparative to obstetric providers. And again, concluding that different professional milieus may create divergent moral views on pregnancy, status of the fetus patient, and maternal duties for fetal well-being. And I think that the different ethical milieus and ethical sensitivities here that these authors are uncovering could be explained by different ethical perspectives that are used in our respective practices. So from an obstetric ethical viewpoint, reproductive autonomy framework is often taught and referred to. It's written extensively on by Dr. Ravitsky, who's now head of the Hastings Center, Frank Chevernak as well from Cornell, which states that really fetal and antenatal testing informs the pregnant person to make autonomous decisions regarding their pregnancy, and that these decisions are personal and private. And so clinicians have a duty to respect the autonomy of the pregnant patient. That's where the emphasis lies, and respect for bodily integrity. And some have argued around whether or not there's limitations on this autonomy, especially as you cross viability, but that's the general focus. And that differs significantly from the pediatric ethical viewpoint that's predominantly taught, whether you're looking at the best interest standard or at the minimal harm threshold. The consensus that was published in 2020 shows that really the focus is on that the parents are the optimal decision makers for the child, and that we should entrust that they have the child's best interests at heart, but that the clinician's primary responsibility, that's number 3 here on this table, is to protect and promote their pediatric patients' health and interests. So you can see the contrast from that of the reproductive autonomy framework. However, we also have to remember that in applying that pediatric ethical decision-making framework, newborns and periviable infants are different, and how we view them is also different. And that this has been borne out by study Andy Janvier, who's a neonatologist in Canada, who's written extensively on this, did a survey in which they presented clinicians with different cases at different ages, ranging from 24-week preterm infant all the way up to an 80-year-old, and asked the question, would you think the resuscitation is in the best interest of the patient, and would you comply with a family request against that recommendation to provide only palliative care, for example? And there were similar chances of survival and similar probabilities of having a normal outcome for survivors and developing of new major disability. So, for example, the 24-week infant, 50% chance of survival, 50% normal outcome of survivors, but a 25% chance of new disability. Same for the 2-month-old case. And for the 80-year-old that they had in this case, 50% chance of survival again, but no chance of a normal outcome and a 50% chance of new disability. So in that setting, and focusing on those 3, for the 80-year-old, you can see that the majority of providers that were surveyed said that resuscitation was not in the best interest of that patient. And coinciding with that, felt that they would comply with the family's request to withhold, showing again that if they felt something wasn't in the best interest of the patient, they would go along with a family's options to withhold that treatment. For the 2-month-olds, there was wide consensus that resuscitation was in the best interest. And so they would not comply with the family's request to withhold something that they felt was within the best interest. And all of the other bars you can see fit that correlation, that if you think it's in the best interest, you wouldn't comply with the request to withhold. If you don't think it's in the best interest, then you would, except for, as you may have seen by now, the 24-week infant, in which the majority of providers felt that that resuscitation was within the best interest of the patient, but they would comply with the family's request to withhold resuscitation, which shows that perhaps we are using different values or ethical considerations in making this decision beyond what our personal views of best interests for the patient are. Then in regards to reproductive decisions and parental decisions, we have to remember that whereas birth traditionally represents a transition from reproductive decision-making to parental decision-making, periviability creates an overlap of these two constructs. The fetus is potentially transitioning to a newborn, and the pregnant person potentially transitioning into the role of the parent. And I think the literature that I have shown here has really presented these processes as really conflicting, that these are very conflicting views and create conflict in periviability counseling. But I think there's actually potential here to put these converging perspectives together to actually improve periviability counseling. And I think that really begins by getting guidance from the pregnant person, because goals and feelings in pregnancy are not uniform. Complications such as extreme prematurity spark intense emotions such as guilt and grief. They may have caused periviability. They might have caused a preterm labor, for example. Counseling specifically geared to reproductive autonomy, I think, may minimize the pregnant person's perceived role as parent if they're really viewing these consultations and wanting to find out more about the outcomes for the infant and viewing that as a parent. That might not be fitting with an approach of a reproductive autonomy framework, and vice versa. But counseling specifically geared towards parental authority and responsibility to the potential child can minimize the pregnant person's identity and needs as a patient and human. If their emphasis is really on, am I going to survive? Am I going to be able to have kids in the future, for example, then solely focusing on the outcome of the child, again, may not be the most supportive. So I think joint counseling that begins with eliciting the pregnant patient's perspective on their own transition and viewpoint could provide a really important direction for providers to take. And so essentially, I think, there we go. What I'm referring to is creating more of a yin and yang approach in which you have both obstetrical providers and perinatal providers together, because it's so intertwined and intermeshed in this liminal state that we need to be able to support pregnant persons in this kind of dual nature of them being autonomous and deciding about their reproduction, but also considering themselves as parents and what decisions and how that might impact their potential child. So an improved framework for joint periviability counseling would be that it's more patient-centered care, listening to the pregnant person's perception of themselves and their fetus to begin, protecting their reproductive autonomy, but also making them fully informed regarding the outcomes. It's insurance that the pregnant person is informed of all available options, including termination, comfort care, and trial resuscitation, and not only informing them of the things that are emphasized in sequential counseling, as I mentioned earlier. There's availability of appropriate specialty to answer key questions that inform decision-making, and so decreasing the risk that you might defer a question that doesn't get answered. Complete understanding of transition from autonomy to limited parental authority, and a more complete dialogue regarding the social ramifications of prenatal care and counseling. Obviously, it's easier to say that than it is to actually achieve it. We're going through a transition actually right now at Mount Sinai of promoting joint periviability counseling, seeing that there were pitfalls in our sequential counseling of potentially, offering certain things to some others when initially counseled, and then changing that when another provider comes in and counseling. So trying to have a more of a consensus as an institution and across the different specialties. And so myself, Andrea Weintraub, and Catherine Gutman, who are also neonatologists with me at Mount Sinai, are doing a qualitative study of OBGYN, maternal fetal medicine, and neonatal provider perspective on periviability counseling, asking them about their views of periviability counseling in the past, how they've been educated, on their approach to counseling, their feelings of joint periviability, and also the ethical roles and the duties of the providers in counseling. So we've completed around 30 interviews so far across the specialties, and are looking at the data now, and hope maybe in the future can come back and share those results with you. So in conclusion, periviability spans from 22 weeks to 25 weeks of gestation and continues to evolve. The ethical frameworks, though, that underlie how we draw these thresholds are timeless and should continue to explicitly guide where we draw the line in terms of offering resuscitation or obligating resuscitation. Up-to-date professional guidelines published and local data should continue to inform the institutional approach. And I do think standardizing that institutional approach is very important to decrease variability across different providers and what different providers may offer. Providers should acknowledge their own ethical perspectives on periviability and consider joint periviability when counseling if feasible. And periviability counseling should inform parental judgment, which should be respected when outcomes are uncertain. So in that zone of parental discretion, specifically at 23 or 24 weeks, or wherever your institution draws that conclusion. Thank you so much for everyone's attention and opportunity today. I've left some time for questions, and I've left my email as well if people have comments that they'd like to share. Thank you.
Dr. Drago, thank you so much for this excellent talk. Dr. Bayat has raised her hand.
Hi, good morning. Thank you so much for your presentation. My name is Lily. I'm one of our abortion care specialists here. So my first disclosure is that my lens is most definitely biased towards the maternal autonomy perspective. But I think in this post-Dobbs world where abortion is banned in a lot of places, I'm struggling a lot with this concept of mandating any kind of resuscitation during a peri-viable period, especially because viability is a moving target. And I worry about implications that this will have on maternal access to pregnancy termination services, especially when we consider the fact that the data is pretty clear that states that don't have access to abortion care, states that have banned or heavily restricted abortion, are also the same states that have the least access to maternity and neonatal care and have the worst maternal and neonatal outcomes too. So I was wondering if you could just sort of share your thoughts on how this counseling or this discussion would be different for somebody who's working in a different state. I know that at Sinai, you guys have a very robust family planning presence, and New York is very different than a lot of places in the state and the country. But I just worry about this being used as something that people use to promote and legislate abortion restrictions even more than they already have.
That's a wonderful question, and thank you for raising it. There's been a couple of things written about this recently too, in the Hastings Center report by Minkoff et al., and in arguing about needing to keep pregnant persons' rights and fetal rights on the same level, and not using providing extra weight to fetal rights in this ongoing conversation or after Dobbs, for example, on whether or not pregnant persons should be compelled to undergo C-sections for fetal indications, or take medications for fetal indications, as an example, because I think that there is concern that this has opened the door to also those next interventions that you talk about. And also Mark Mercurio and Dr. Eichenwald from John Laswell, Philadelphia, wrote a Pediatric Perspectives in Pediatrics that just came out in February, actually, talking about some of the recent executive orders and that requiring resuscitation of live-born infants after birth, and the fact that actually could go against the rights of that child to have a surrogate decision maker for them, that all patients within medical care have the right to make a determination if the medical care that is an option for them is a benefit that outweighs the risks. And it's a well-established ethical precedent that if you as a patient feel that receiving a certain treatment, the risks outweigh the benefits to you, you have the right to refuse that intervention. And so newborns as well should have the right to have a surrogate decision maker that factors in those risks and benefits. And so they make that argument, the importance of maintaining that. Unfortunately, these thresholds are something that does come around, and looking at the data, as we get better at neonatal care and deciding kind of what to do for infants, what becomes difficult is when survival becomes almost 75, 80%, 100%, it becomes very difficult to look at that and say that there is a question that is of uncertainty to be offered to parents. I think that is where it's difficult, and where I think language is really important. I mentioned a few times that we talk about parental wishes, and I think that terminology actually diminishes the weight of parental judgment in these considerations, and we should be referring to it as parental judgment, because when outcomes are uncertain, I think that deferring to parental judgment and allowing them to have a say and factor in other things like family values and personal beliefs is vital and should be maintained. So I hope that covers a little bit to what your question was.
That does, thank you. And sorry, Dr. Eber, if I can just ask one quick follow-up question. When you guys counsel your patients, or when you're thinking about models to use for your perinatal or periviable counseling, do you take into consideration what the neonatal and pediatric health access is like in the state or town that the patient is in? I'm just imagining that matters for a parent's decision making, just because I see that a lot in abortion care, right? So if you have a periviable fetus and a mom is making a decision whether or not she can access healthcare for her child might impact her decision about what intervention she wants to do or doesn't want to do. So all of the studies where we're looking at outcomes, are we taking into consideration the bigger context of what is the actual health access for that baby and for those parents? And does that matter? Like really looking at it from a long-term perspective.
Yeah. I think it's a great question. I know just looking at palliative care options, for example, only 50% of children's hospitals in the United States currently have pediatric palliative care board certified providers. Mount Sinai does not have a full-time. I came and did a course at Harvard in the palliative care education and practice to improve our palliative care for periviable infants and other infants with life-limiting conditions, because I noted that there was a gap in that care. And if you go to perinatalhospice.org, for example, that website tracks access to perinatal palliative programs across the country. And you'll note that similar to abortion care, there are large gaps. And I think that the palliative options to provide care for families that do wish to go forward with the delivery, but don't wish for aggressive interventions or extended intensive care, that is a large gap that needs to be filled. And I'm involved with a number of neonatologists to work on workshops to try to train and improve that care. But it is something that's growing, I think, in terms of our awareness of it as the situations continue to evolve.
Thank you. I see that Dr. Sharma has her hand up.
Thank you, Dr. Drago, for this very thought-provoking talk. I'm Ruchira. I'm one of the MFM providers. It's actually very nuanced and very difficult and sometimes multiple stage conversation with the patient when we are counseling the lower limit of periviability. And in our institution, we have I think our neonatology colleagues have come up with offering full resuscitation at 22 weeks. And I usually use the NICHD calculator, really printed in, and when I go in the room with to talk to the patient, especially when the survival data is so low. It's like anywhere between 5 to 11 to sometimes 30%, depends on the gender, depends on the weight, depends on whether we are going to give steroids or not. And I always wrestle with the idea that, is this NICHD data even relevant, especially in our institution? Because anecdotally, I haven't seen any 22-weeker survive in my 3 years in the institution. So I at every forum, I ask my neonatology colleagues, what is our data? Has any neonate in 22-weekers survived? And I always, I've never gotten an answer. So what's your take? Like, how should, if there is no institutional data, then we only have the NICHD to guide, but I don't know how much of that is that truly the outcome data, where that patient is, and is that the outcome that's really promised to the patient?
Right. I think it's a great question. Anytime I think you are counseling, and we included this in the Yale guideline, which is on the up-to-date chapter, which I encourage you to look at. That approach also states that if there are limitations in the care that you are discussing at your institution, talking about potential referrals to other institutions, but also being open about and transparent that this is national data. Here at our institution, with the numbers being smaller, we don't have those outcomes available. And we do know that if you are at an institution that has a far lower volume of these patients, that your outcomes will likely be worse than an institution like Iowa, for example, that has risen in terms of their numbers. They have a very rigorous small baby unit. They actually came to lecture at Mount Sinai recently as we were updating our small baby guidelines, and we were very interested to hear about their approach and their outcomes, because their outcomes in 22-weekers are even higher than what's published in the Periviability guidelines or the NICHD calculator. So I do think that local data matters a lot. Again, I think I wouldn't get too bogged down sometimes in the numbers themselves, but rather use them as a reference, and noting that outcomes might be slightly better or slightly worse, and that certainly your own neonatal providers data factors into that.
Thank you. I see that Dr. Rosen has his hand up.
Dr. Drago, I'm Todd Rosen. I'm the director of MFM here. Thank you for a really wonderful talk. I think it's tied for my favorite talk on the topic with Dr. Mercurio, who also speaks really well on this topic. Hey, this is my question for you. Sometimes we have a patient, like once the baby's out, it has rights, and we can't forget that. This is very different than a termination question. I've had cases where the baby has an extraordinarily good prognosis, but a congenital anomaly like a neck mass, and the parents have asked us not to resuscitate, and we've said, no, we're resuscitating. Like no question. But this is my question. New York recently, in the recent past, changed their abortion laws to be more liberal. They allow a termination of pregnancy all the way up until term. Do you think we're obligated in the case where a patient wants no resuscitation, but we're refusing to do that, to offer the patient a termination? Because at that point, that's going to help that patient achieve the goal of not giving birth to a child that has a high rate of disability. So it takes a decision out of the neonatologist's hands. And if you think that's a viable option, are there providers at Mount Sinai in New York, where you are, that would help a woman terminate a previously wanted pregnancy because of the uncertain prognosis for that child once it's born?
I think it's a great question. I think that my understanding is that within those laws beyond 24 weeks, that there are within those statutes comments around the medical issues of the fetus, if I'm not mistaken. And so when these situations come up, it's often a conversation between MFM and neonatology to determine whether or not it is reasonable to say that this is a significant medical issue that the fetus has, so that we would be acting within the law to offer that termination. Because if it is legal, if it's something that the parents want and understand, then I think that you can do it ethically and legally as well. I think that where things become difficult is that some of those kind of severity of medical issues, et cetera, can be vague, and they can be a value judgment, and may have to go to an ethics committee, for example. And I would encourage, I sit on our ethics committee, and we've had not prenatal cases that have gone all the way to ethics committee, but we have had postnatal in regards to withdrawal of care, continuation of life-sustaining therapies in newborns go forward, particularly in HIE cases. And so I think getting an ethics consultation at that point and making those considerations and doing due diligence in that counseling is vital to find a way through. It is a very difficult issue.
All right. Well, Dr. Drago, we're just about out of time, so I just wanted to thank you again for this excellent talk.
Thank you. Thank you for everyone's questions and for inviting me today.
Yes, thank you so much. All right. Well, I hope everyone has a safe and successful day. Thank you all very much.